Now, as it stands, the Western Cape has 12,888 confirmed cases of the coronavirus outbreak. Concerns have been raised about the high number of infections in the province and whether lockdown regulations are being adhered to. On Thursday, it was reported that 105 hospital staff tested positive for COVID-19. And we've also heard reports about the lack of quarantine facilities for medical staff who do test positive. To continue this discussion, I'm joined by Kweleta, he's the Provincial Secretary General of Nehawu, as well as Nomafrench Mbombo, Health MEC for the Western Cape Province. Good morning to the both of you, and thank you very much for joining us here on Weekend Dawn. MEC, I'm just going to rope you in and perhaps pose the first question. Just looking at the Western Cape and perhaps the scale and the nature of the tests that are currently being conducted compared to the rest of the country, and perhaps looking at the figures that are coming through. The Western Cape, as it stands, accounts for about 60% of confirmed cases in the country to date. Is there a possibility that the Western Cape Province residents are perhaps not adhering to the tight regulations as it stands? What are some of the other variables we have to factor in?
It's a various contributions. No one answer will be able to paint the picture. One, we have to accept the fact that the virus, the epidemic is here, as been predicted at a national level, that by August, September, there will be over 1 million of the people who could be infected in South Africa. And currently the modelers, they also projected that by that time we could have 40,000 or so of the people who had died from the COVID. In the Western Cape, we also had our projections where actually we saw that it could be earlier in June, not actually in August. So we see the epidemic now that has come earlier. Number two, the high level of the infection is about, for us, it started with clusters, big clusters that were there during lockdown level 5. Through the essential service workers, from the retail, grocery stores, supermarkets, to the factory industries that were open at the time at level 5, a law enforcement agency, which is where we've seen police stations across the province where people were infected, the correctional services, and now we are also seeing in the old age homes. So all of these are essential service workers. And now these people, when they go back home where they reside, which is not necessarily at the same workplace area, they ended up infecting the others. And these homes, as the labor force people, we find that it's a high-density communities where there are elements of overcrowding. It ends up creating what we call hotspots. So we see at the national level, if you recall, at the time that Professor Karim was presenting with the National Health Minister, the hotspot, it was at the stage 5 where the country would be. So we came earlier to stage 5 of the hotspot, whilst the country is still under that kind of a most community screening and testing. So that's why for us now in terms of the testing, that you have to change the strategy and go find those cases, case finding targeted, instead of just doing the spray gun approach and randomly testing everyone. So if you have got one shop that has got 50 people infected and they are coming in 4 areas in Cape Town, we have to go and find those, not only those people, but also go into the communities and get those cases that are positive.
All right, Eric, just before I rope you in, MEC, whilst I have you, I just want to actually look at the hotspots, particularly in the Western Cape Province. You cited that contact tracing is something that you're also working on, perhaps as part of your broader strategy. But just looking at the hotspots in the Western Cape, the demographics, making some of the populations perhaps more vulnerable, or even just some of the social determinants. What do those hotspots look like?
If you look in terms of the metro, in the city metro, it's divided into 8 substructures, how it's being managed. In each and every substructure, you'll find that you may have 1 or 2 areas where there's a high level of the local community transmission. Plus also when you do the testing, you find that there's a high positivity rate. So it's an area also where in the last 14 days you find that again you get many of the positive cases. Plus also it's mostly in the vulnerable communities. So if, for example, in those hotspots, what we have done, like in the western, like in the Danun area, is a hotspot. In the Tigerberg, it's for the whole of the Tigerberg area. It's in the Cape Flats, all hotspots, in the Khayelitsha and all of those. What we have done, we have applied or implemented the whole of government strategy and the whole of society, meaning not only you look at the health response in terms of the contact tracing, the quarantine, the isolation and all of those, but also to work with our Department of Safety in terms of working with also police for the restrictions in those areas. Department of Social Development for the humanitarian implementation approach in those areas. The Department of the Human Settlements to look in terms of the de-densification or reblocking of the areas, especially if it's in informal settlements. The Department of Economy working with the industries, sectors, different sectors to come up with what kind of the protocols or the guidelines that could be utilized in a certain industry for the workers and also for the employers to be able to implement some of the regulations related to the occupational health and safety within the Department of Labor so that it will stop the spread. Plus also from the health perspective to put more staff, the epidemiologists and all of those other categories, social workers, to have these teams of the people that you can go in there and divide one area. Let's make an example of Khayelitsha, where you cut it into 6 areas, A, B, C, D, and 3, F, where you know that from A, you do street by street and all of those. So that's part of the approach for the hotspot, when you have to divide the area into smaller chunks and mop up.
Now, as this risk-adjusted approach, is obviously phased in, Eric, I'm going to perhaps also rope you in on this conversation. Based on what the MEC has just said, I want you to unpack some of the challenges and concerns that the frontline essential workers are facing during this time. I mean, there have been reports and concerns about a lack of adequate quarantine facilities for the workers, in fact, who tested positive, amongst some other issues. Paint that picture for us.
Yeah, first I want to start by saying over and above, this is a manifestation of the socio-economic fabric of the Western Cape, which is highly divided between those that are very poor and affluent ones. There's quite a number of contributing factors. And we also want to raise, as you've heard the MEC speaking of, the feeling of vacancies in the staff. This is a deep-rooted problem that has been there, which currently finds expression. As for the quarantine side, look, from where I stand, I currently do not know what is the plan of the province in terms of responding to COVID. We've tried now since March already, written to the MEC as the union to understand what's the common approach. We've written to the Premier, we have not had any response. So we are in fact just reacting to what our members and the ordinary workers are confronted with on the cold face.
All right, MEC, I just want to also then, pose that question to you based on the approach that stance you've taken in terms of the approaches that have been implemented and also just looking at the possible challenges and concerns for projected cases. I mean, what are some of those challenges that you have cited or that you foresee, should the number of cases increase and should more frontline workers be exposed to the coronavirus? As I mentioned in my introduction, there were reports about a lack of adequate quarantine facilities for frontline workers who tested positive. I mean, what's your stance on that?
Taking note that the health worker is also another cluster on its own. I made an example of a police correctional service cluster and also other clusters from the supermarket. Health workers are also another cluster on its own. And unfortunately, these are the people who also have to respond and bring services to the whole of all other people infected. And therefore, we take it very serious, this kind of a cluster. That's why, one, we have to prioritize the testing for them. As you might be aware that in the country now, it takes longer to get the results because the national lab is inundated because many people want to test, plus also in the private lab. You cannot wait for longer for a health worker to be waiting for the results whilst things need to happen. So we prioritize them for those. That's why even from the beginning, we kept on saying that the N95 mask, they need a surgical mask needs to be, for those ones, to be preserved for the health workers. For example, if you are working in maternity, what kind of a PPE, protective clothing that you need to require, where you have to wear those white suits when you are delivering, what kind of a PPE when you are working in the primary care, in the clinics, what kind of a protective clothing when you are working in the ICU, as according to the national guidelines, but we took it further in terms of, especially the areas of the hotspots. Currently, what the Honorable Nehawu was speaking there about, they didn't receive any in terms of the strategy. As part of the bargaining council, we also have got even at a local level where each and every area we have been actually sharing our strategy, which we've done it now in terms of the substructure, but also at the facility base. Now, lastly, in terms of the readiness, we envisage that in a pessimistic scenario, we'll need about 2,152 acute beds by the hospital. Currently, we have 1,504 in the public space when we combine all of those requirements. I'm talking about the COVID. So therefore, that's why we are now working around here with 658 beds so that we could be add to that. But the most important thing is the ICU, the critical bed capacity. Both you made an example of the Tiger bed. We've got 106 ICU beds, which are getting fuller. That's why already we have signed a deal with the private so that they could be able to give us extra 200 beds for the ICU. Ideally, we want to have it to extend it to 100 for our own, but to get the ICU trained nurses and also even the other staff like the doctors for the ICU. It's even an international challenge. And then lastly, the CTICC for the intermediate bed capacity is ready by the end of the month to be functional. We're appointing staff and even call and ask the National Health Minister that the minister adjust the movement of the staff specifically to appoint, if there are nurses outside the province, that we could be able to fast track so that even the doctors, as same applies with the GP, so that make the point that when we open the CTICC, when we open the R3
I'm going to have to leave it there. Thank you very much. MEC for Health in the Western Cape Province, Nomafrench and Mbombo, as well as Eric Kweleta, Provincial Secretary General of Nehawu, just chatting to us about the COVID-19 situation in the Western Cape Province. Again, just looking at the numbers coming through, perhaps Cape Town as the hotspot, and perhaps what are the measures that have been put in place to ensure for the projected cases that are yet to come.